Hello everybody, welcome back to the Technologist workshop. I know it's been a hot minute. We've had some pretty busy days around here, so I apologize for that. Anyway, let's get started. Let's go through these x-rays and see maybe what went wrong and what we can do to correct those. I've said for a long time that image critique is the best way to learn about what you need to see on an x-ray to make that x-ray diagnostic. And when you get better and better at this stuff, it's going to be a lot easier. So I encourage you to look at these videos and learn from them. So let's get started, okay? So with these, we start with a note. Now, these x-rays have been taken off of our one-pack system, just in our different clinics, and just a few things that I've noticed that need to change. This is actually a pretty big one that I see a lot, is hanging films upside down. Here we have an ankle x-ray. It's actually a pretty good ankle x-ray. Whoever did it did a nice job. The problem lies in the images being upside down. And there is a video out there that I've put out on hanging protocols, and it explains how we hang images to make them look good for the provider as well as the radiologist. Looking at an anatomical picture, it's nice to see it anatomically correct versus upside down. So if you have taken images upside down, it's not the end of the world. At this point, you just need to start practicing flipping those images post-processing so they look accurate on the screen before you send them off to the radiologist. So you can see that there's an AP, there's an oblique, and there's a lateral. Great job doing the images, but they're just upside down. So here's what we would do to alleviate that or change that. This is how we're supposed to hang an ankle x-ray or anything lower extremity, feet down basically. This is the same ankle, believe it or not. And it looks good. It's hung correctly. It's a nice picture of an ankle. All the joint spaces are seen really nice. And the angles are well. We've got a Mortise angle here where we can see that talar dome really well, and the joint space between that and the tibia and the fibula. We've got a really nice joint space here on the lateral. We got the talar dome there again. So these are great images. The only difference between these two is one's hung right and one's hung wrong. So just make sure you're hanging your ankles and feet down, okay? Remember, hands up, feet down, okay? All right, let's move on to the next one. This was supposed to be an abdomen x-ray, and it was turned in for reading. It's obvious kind of what we can see is wrong here. For one thing, our centering point was a little bit low. Now, for an abdomen, most of the time you're looking at the iliac crest, which is this bone right here, perhaps a little above it for an upright. But you can tell that we kind of centered down here, mid pelvis here. And it shows we only need to catch the top of the pubic symphysis right here. So the bottom of the film should be right there, which is going to allow us to see a little bit further up the body. And it's also mis-centered, so we're only getting the right side of the abdomen. On an abdomen x-ray, we need to see the entire abdomen. Both sides, preferably both skin margins, both right and left, okay? And like I said before, your bottom margin is going to be the pubic symphysis, and whatever you get above that is good. So to make that better, we're just going to change our centering point, and we're going to make sure that our central ray is at the mid-sagittal plane, which is going right up the spine, right? And we've got the pubic symphysis here. If anything, we could move up another inch or so. Looks like our centering point is just below the crest. So if we'd have moved up to the crest, we would have been pretty close right here. Just want to see the top of the pubic symphysis right there, so they can evaluate the bladder and those things that are down in the pelvis area. But again, this is a nice picture. It's a nice KUB. Everything's that needs to be there is there. Okay, we've got both right and left skin margins involved. We've got the pubic symphysis. And kind of hard to see the kidneys due to the stool and the bowel gas. But I'm assuming this is the bottom pole of the kidney right here. I can't really see the top of it. So if we just centered a little bit higher, we would have got the top of the kidney. I can't see one on this side, however, which is normal. And there's nothing we can do about that if there's stool and bowel gas in the way. Okay. On them abdomens, just make sure you're centering at the iliac crest, and you're going to get it most of the time, unless their body habitus is a little bit leaner. Anyway, so that's the abdomen, guys. So we went from this to this. Okay. Just make sure that you've got your body part included in the x-ray. Okay. Let's look at an AP shoulder. Okay. Not a bad shoulder. You know, it's positioned fairly well. The collimation's a little bit wide open for me, but you know, not the end of the world there. The biggest reason I put this one on there is to show that bra straps are a hinder for shoulder x-rays. So if you're going to do a chest, shoulder, even a clavicle, scapula, humerus, anything like that, you're going to want to have them remove the bra, because those little clips that hold the strap together, they can be a nuisance and be in the way. You'll note that this one, this clasp right here, or whatever they call that thing right there, it's right in the middle of the shoulder joint. Okay. And that's the area of interest usually when we're shooting a shoulder. So just make sure they're taking their bras off, you know, unless it's a sports bra that doesn't have any sliders on the sleeves or the straps. But most of the time you're going to have them take that off just so it's not in the way of anything. Okay. So we look at this image, it's a pretty good image. You know, if those clasps, whatever they're called, aren't there, it'd be a lot better image. Everything's demonstrated that we need to be demonstrated. I would have just collimated a little bit tighter. So, all right, let's look at this. We went from this to this. Okay, now you can see that without the bra straps, we can see that joint space a lot better. So, collimation's a little tighter, which is great. You can see it in the image quality. You know, on a shoulder x-ray, we want to catch that sternoclavicular joint right here. Okay, we want to make sure that that's demonstrated. We want to see the entire clavicle coming over the acromion right here. The coracoid process should be staring right at you, which it is in this case. I believe this is an external view of the AP shoulder. We've got a slight superimposition of the humeral head over the scapular or the glenoid fossa, which is what we want to see. So we went from this with the bra stuff in the way and a little bit open collimation to this. Remember, we're going to start at like a 10 by 12 collimation with the shoulder, and most of the time that works really well. Just make sure to include what you need to include, which is the sternoclavicular joint all the way out to the lateral skin margin of the deltoid right there. Okay. We want to strive to include the entire scapula, which we did. You can see that scapula coming down into the lung tissue and then riding back up to the top there. Okay. So very, very nice image. So this is what we want to see, guys. Just to reiterate what we went over a little bit, ankle, feet, tib, fib, knee, they're all going to be hung from the pelvis. Okay, so that foot is going to be down. It's going to look like this. Okay, just really strive to work on this. I do see a lot of images that come across upside down, and I guarantee that the radiologist cringes a little bit when they see those. They want to be able to see it anatomically correct. So just take special note of that. If you ever have any questions, call me and I can explain how we hang something and make it look anatomically correct. Then we went to an abdomen, a little off center, centered a little bit low. It's not centered with the mid-sagittal plane like it should be. And we ended up with this, which is a good picture, but could be centered a little bit higher, but nonetheless good picture. And then we talked about the shoulder, no bra straps, tighten your collimation a little bit. Okay. All right. I just thought I'd throw this in here. We know who Lindsey Vonn is. She's an American skier that broke her leg in her first run at the Olympics. Anyway, these are her X-rays of the leg that she broke, and it's pretty extensive fracture. I mean, there's a lot of comminution there and pieces everywhere. You can kind of see where her boot ended, right there and right there. Sometimes that happens with ski accidents, is that boot is so stiff that everything above the boot, once it gives way, you can see where it kind of gave way right there and right there. But nonetheless, pretty impressive fracture. Long road of recovery for her. We're looking at some post-op stuff here. I know she was in an external fixator for quite a while. It's where they go in there and put the bones back together, and then they run some screws in it to hold it in place. The actual fixator is on the outside of the leg. It actually does a pretty good job until they can get some hardware in there. So anyway, kind of a cool picture, I thought. Anyway, thanks for coming by today. Thanks for watching this. I urge you to pay close attention to what you're doing when you're positioning the patient. And then once it comes over to the computer system, remember you can change the way the image looks, direction, contrast, density. You have that at your fingertips. So I probably ought to do a video on how that works. Maybe I'll do that here in the next few weeks. Anyway, I appreciate you. If you have any questions, as always, please reach out to me. I am available anytime. So, and I enjoy talking about X-ray and helping people along. So, anyway, thanks, guys. We'll catch you next time. Bye.